it's not an easy job actually for me as a mom, and I've got other children as well to keep an eye on them. She's got two younger brother and sister younger than her, and with school, and they haven't got any extra hands for here. I totally by my own, and just my husband hand actually. At the beginning, it was really hard to manage all the medication, nebulizer on time, school on time, and we had quite difficult time because my ab has got, sometimes she needs to be in hospital for 2 weeks continuously with IV antibiotic, which is really hard to juggle family commitment. My ab in the hospital, and she doesn't want to stay by her own at all. So either me and my husband has to be on her side, and one of us will be at home. And obviously here by my own, I haven't got my extended family with me. It was really hard, but in the end we got there. We got the routine, how to fit the medication, and my ab has, by all means, she has to wake up earlier than other brother and sister, and she was, at the end she found it, at the first time she found it quite unfair. Why shall I need to wake up earlier before them? Say you have got some things he has to do, and she has to do some medication in the stage and then have physio. And as a normal child, you have to make sure that he's got the breakfast and dressed well and off to school. But with my ab, it's quite different. She has to manage her exercise very well, her medication, inhalers, antibiotics. She's on antibiotic ongoing one actually, and then she has to go to school and she has to manage all of that on certain time, definitely.
When the boys were diagnosed, we had to start doing daily physiotherapy. It was twice a day. So our daily routine was completely different to what it was before, and we used to have to fit in physiotherapy 20 minutes in the morning and 20 minutes at night. And so some of the things that we did as a normal family, and routine is quite important to us anyway, which is quite useful, just went by the by. So things like having a long bath and a story every night became a short bath and no story. So hence Gregor actually was quite late in learning to read because he didn't have that reading, which was a shame. But his chest was much better, so they were very good at learning how to do physiotherapy. Giving them tablets and medication was slightly more difficult. When they were small, they used to have lots of oral antibiotics and a syringe, and we often used to have to sit on Gregor to actually physically get it into him. So that was quite difficult.
It's important that Dad's involved in the day-to-day care of the children for two reasons. One is you really need to know and understand what it's all about, and the second thing, you do need to share the load with your wife or partner. I think it's really important. I think it's important that you understand what's going on in the regular care of the children, and in lots of cases it will be impossible to go to all of the appointments with the consultants or the doctors. So therefore it's important that you know when the appointments are, and that you have a conversation with both the children and mum when they come back to understand what's going on. The other thing I do is to make sure I read all the letters so that I know what's going on with the correspondence between the GPs and the consultants and vice versa.
Regardless of the age of patients being referred to us, we apply the same rules of history taking, examination, investigations for all of these patients that we think might have PCD. The first thing we do is we get the family and the patient in, and we discuss the history. So we're very interested from not just the time they were born, but from before when they were born. There may be clues that would make us think this is PCD. The obvious one is if an antenatal scan has picked up situs inversus, where all the organs are in a mirror arrangement, and so an alert obstetrician or ultrasonographer at that stage might raise the possibility that this child has PCD. When they come to us, we want to know what they were like after they were born. Have they had problems with respiratory distress from the very beginning? Have they had problems with rhinitis or ears, or have they had recurrent chest infections? What symptoms have they had from a very young age? And it doesn't matter if the patient comes to us when they're 15, we still want to know what that newborn or antenatal history is. So we go through a very detailed process of finding out all that information. Then we'll sit with the family and say, we think this might be PCD. and we explain to them exactly what we're going to do to try and confirm that or exclude that as a diagnosis. So the first thing we do is we try and do what we call screening tests in them by measuring a gas called nitric oxide from the nose. Now this is very easily done in anyone that's 5 or 6 or above and is able to hold their breath. So all of those patients would have a screening test. In the younger ones, we now have brought into practice a slight variation on that test where we can measure it during their normal breathing pattern. And so that's less accurate but still very useful information for us. If it's very low, or we think there's a very strong possibility that this is PCD, we will then start talking to the family about the diagnostic tests, which involves taking a little brushing from the nostril to get a layer of cells that line the respiratory tract. And we have the same type of lining in the nose that we would find throughout the lungs and the tubes draining the ears. And so what we want to do is have a look at that under a microscope so that we can see whether the little hair-like processes called cilia are working properly. And that gives us a lot of information. What we do before we go ahead with this test is talk to the family, and particularly the older children as well, to explain what this test will be like. It's brief, it is a bit painful, it's uncomfortable. I've had lots of them done for research purposes. And so we tell them all of that so they know what to expect. We also tell them what to expect if it's a positive diagnosis. It's very important for us that if this comes back as looking very abnormal, that they're actually beginning to think what that's going to mean for their child, for the family, and for everybody involved in this patient's care. And that's probably the key thing to do before we go ahead and do the diagnostic test, so that we feel like we've given some sort of background information and some information about what will happen once we get the results of the test back. Then they will go and have the brushing done by any member of the PCD team, all of whom are trained to take brushings. And on that same day, we will make a phone call to the family to say what the sample looked like. Now, the nature of having PCD means that you tend to have a very blocked and runny and inflamed nose. So taking a brushing, even when a patient is well, is a little bit fraught in terms of trying to get a really good sample. And so we warn the family that the first brushing might not give us adequate amount of lining cells to the nose for us to actually make the diagnosis, in which case we will have to arrange to do a rebrushing. In the event that we have got a good sample, we can phone them that day and say, this is what it looked like under the light microscope. So, for instance, there will be the normals, where the ciliary beat frequency and the ciliary beat pattern look entirely normal. All of our samples are then stored and sent for EM, electron microscopy, which is the definitive diagnostic test at the moment. If there was any hint that it was abnormal, or the screening test was very low, the nasal nitric oxide level was very low, or that the clinical picture is so typical of PCD, all of those will be analysed at electron microscopy, and that test takes about 4 to 6 weeks to come back. At that point, we will already have arranged to see them in clinic in 2 months' time. We can go through all of the tests they've had and the results and explain what we're going to do if in the situation that the diagnosis is positive for PCD. Following on from that initial clinic visit, where we also will introduce them to the entire PCD team, just by nature of the way we run our clinics here at the Brompton. We would have a clinical nurse specialist meet them if we felt there was a very strong possibility this was going to be PCD. We have nurses who are very experienced in PCD, and they will give direct contact numbers to all the families so that they can call with questions that they might have following going through this process, following the initial counselling, because they'll go home and they'll think of things and they'll want to speak to someone. We also introduce them to a physiotherapist who will start them off on physiotherapy techniques for their child's chest. And we do that regardless of whether we know the diagnosis or not at that point. We want to start them on treatment. And there may be other treatments that we feel that they need to have from that initial visit that will start to make them better from a symptomatic point of view, such as antibiotics or inhaler devices, for instance. So hopefully anyone that we think has a strong suspicion of having PCD will have met quite a large number of the team on that initial visit, and they will have a direct point of call that they can use if they have questions or anxieties. As they continue on in our clinic, they will see these people in every clinic visit that they have here. So whether it's our specialist dedicated PCD clinic or one of our general respiratory clinics where we also see a lot of PCD patients, they will still see the clinical nurse specialist and they will still see the physiotherapist. And they will develop quite a relationship with these people because they will phone them up and have queries about things that are happening to them in other hospitals, things that are happening in school, just worries they have at home. What do they do when this happens, for instance? And that's probably the most useful part of our follow-up service, actually, is this ability for families to contact members of the team and get those little things ironed out before they become a big issue. The other thing that I think is very important for those families is that they have shared care arrangements with other specialists. So, for instance, they will be hopefully seeing a paediatrician or a respiratory paediatrician local to them. They will obviously have a GP, but they may also have an audiologist, for instance, or an ENT surgeon that they see. And so it's very important for us that we know who's in the shared care arrangement so that we can give out advice, particularly when it pertains to things like ear, nose and throat, because they would be managed differently from other patients without PCD who might have similar problems. Glue ear being the most obvious one, in that we would manage that differently. And so we would try and give all this advice out to the shared care teams to try and prevent inappropriate use of interventions, if you like, in these patients.